Hi, I'm Armand McGibbon. We're at Appalachian Trail Days 2025, and Dr. Skyvorst is going to give us a guide for physicians on knee, ankle, and then dorsal and plantar of the foot, just a little diagnosis and treatment for us to stay refreshed.
Hi. This is Dr. Greg Davis. By the way, he's a forensic pathologist, so we hope that we don't have to encounter him anytime soon.
That's right, yeah.
But he's going to act as the patient. Again, we're Trail Days here. We found out through years of being here that probably 40% foot troubles, about 15% ankle, and 15% knee. So most of the treatment that you see here from hikers in Trail Days is related to this. So we thought we'd just do a quick refresher. Most of the knee problems in hikers are more patellofemoral, which is where the kneecap lies on the femur. So if someone has pain on the inner lining of their kneecap or the outer lining of the kneecap, that's more patellofemoral. Now, there's also pain at the distal pole of the patella, and then also where the patellar tendon goes down into the tibia. All those are extensor mechanism quad type injuries that the hikers get. So there's a lot of this kind of pain. Now, if they have pain here at the medial joint line or lateral joint line, you tend to think they have meniscus or chondromalacia of their knee joint. So those can be a little more daunting. And then the pain over on the far lateral side can be an iliotibial band. So those are the common ailments of the knee on hikers. And as far as what we have to treat them with, we're obviously at an outdoor clinic, so we don't have all the things that we need. We don't have x-rays and all that, but quick treatments are a potential shot if they're hurting a lot, anti-inflammatory gel or pills, and then a sleeve, and then exercises. So we have all those things available to us, and I think that's a nice little refresher on the day.
You just put it under the kneecap?
Put it right now. You can do it several things. So a lot of people will inject it either here or here.
Yeah.
I find those are more painful injections than kind of beneath
Right there.
the kneecap.
Okay.
And usually they're facing you like this, so you just kind of
Now,
feel the inferior pole and inject right
if
there.
it was strictly the tendon here,
Yeah.
you would be reluctant to inject that?
I would, like if they're hurting in their tendon substance or their insertion here.
Yeah.
I don't like to do
No.
that.
Okay.
But the origin of that tendon is fine.
Oh, really?
Yeah, you can
Okay.
inject, because you're going really in the knee joint.
Okay. All right.
So now we're going to go to the ankle joint. So there's a lot of ailments of the ankle on these hikers. So let's do the first thing first. A lot of people have posterior tibial tendonitis. That's pain or swelling on the medial aspect of the ankle, especially where it inserts on the navicular. So you have a lot of pain here. But some people hurt all along this corridor, even up to the posterior aspect of the tibia. On the inside ankle, that's posterior tibial tendonitis. When we're in clinic, we usually treat it with inserts and brace cinched in. Potential shot at the insertion, no, you want to inject the tendon itself, and then therapy and anti-inflammatory gel. So we don't have a lot of inserts here because it would just take up a lot of blood transport. So we generally do a lot of brace work and some therapy and anti-inflammatory.
Where do you shoot?
Shoot at the insertion, right at the navicular texture. Okay. So the next thing, people have a lot of Achilles tendonitis. That can be anywhere from the insertion here up to what we call the watershed area, and then all the way up here. So that's from a tight Achilles tendon. So a lot of these hikers, they're going up and down mountains, and they don't have enough up motion. So like Greg has done a good job of keeping his dorsiflexion leg up, Greg. But if you don't have a lot of up motion, then the tendon starts microscopically tearing you, so it gives them Achilles tendonitis. And the way we treat that is anti-inflammatory pills, core gel, and a lot of stretching. Sometimes we need to do a brace to help them, but there's a lot of stretching involved. But that's usually the cure for that.
The perineal tendon, you can see it here. There's two tendons that run behind the ankle, and one inserts at the base of the fifth, and one goes around and inserts at the base of the first. That pulls your ankle out. So a lot of these hikers are walking on rocks or uneven surfaces, so it really bothers them here. So you can see where Greg's got he's nice and skinny, he's athletic here. You can see where that tendon goes. So the three areas where the tendon bothers them are on the back side of the fibula here, where it goes through the tunnel. The perineal tubercle is a little bony spicule off the calcaneus, and the tendons go through this little tight compartment there, and it can really chafe you there. And then the other spot is here. And the way we treat that, the occasional shots, and then the bracing, and then therapy to strengthen the perineal tendons.
If you're going to inject, where are the places you would?
Probably here's best, and,
Okay.
and there. This is not as good because you're injecting tendons.
I got you.
So you inject that little tubercle area,
Okay.
and inject the base.
Okay.
Yeah. And anti-inflammatories.
And I remember you're saying you can inject beside the tendon, not
Yeah,
necessarily
yeah, yeah.
directly into
That's
the
exactly
tendon.
right. Yeah, you don't want to really inject inside the tendon, but beside it works. So, yeah. Good. the anterior tib is not something I see a lot in my normal clinic, but we see a lot of it here because the hikers are overusing their anterior tibial tendon. And again, with Greg, you can kind of see it here. This muscle inserts at the base of the first metatarsal. You can see where it goes up here. It goes into the anterior compartment here. So people are using a lot of their anterior muscle here to pull up to counteract their tight Achilles tendon. And they're going up and down all these trails. So people have a lot of anterior tibial tendonitis that is a little bit unusual in the day-to-day clinic, but very common here. So you can inject insertion, you can inject up here. You don't want to really inject the tendon, but a lot of that's the stretching and then bracing and anti-inflammatories for that.
Now, we did see one time, just touch, there's a retinaculum in here that rarely, but we have seen it causing problems, right?
Yeah, the retinaculum Armand brings out a good point. You got muscle here, and the tendon kind of starts right about here and goes to here, but that retinaculum keeps the tendon from bowstringing. So if they have a rent in their retinaculum, then their tendon would come up off the ankle and insert there. It makes it less effective, which is why that retinaculum is good.
Have you ever injected the retinaculum?
I don't remember injecting the retinaculum.
No, okay. That would be uncommon, right?
If you go beside the tendon, it's okay, but you don't want to inject the tendon itself. Now, the other thing is chondromalacia of the ankle, where that would be a deeper pain inside there. Again, the hikers are going up and down a lot, so if they're chafing their ankle joint, which is the talus and the tibia together, it wears out their carpet, which is the cartilage. So sometimes you have to inject the ankle there to calm them down on this.
Well, we're going to go over the dorsum of the foot exam. So a lot of these hikers have dorsal foot pain. What is that and how do we treat that? Up in here is more athletic or spraying. These hikers are using everything they can to go up and down hills. Some of them are older, so they have early arthritis in their midfoot. So that would be pain in this area. Pain in this area is more stress fractures. Pretty common, really. We can be young or old because they're putting 20 miles a day. Those stress fractures, the microscopic fracture, the bone, a lot of times it doesn't show up on x-rays, but they hurt in their forefoot in this area on their second, third, and mainly fourth metatarsus. So we try to treat that with anti-inflammatories, with sticking their shoes, make sure that they've got some recent trail shoes. Sometimes we use a Parsons powder plate for that. Now down in here at the base of the toe, some hikers will say, hey, the base of my toe hurts and my toe kicks over toward my great toe. That will be second NP synovitis. It's an inflammation of the base of the second toe. It usually doesn't really happen on the third point and good. Again, the way we treat that is you inject it. And you tape the toe if it kicks over, but it's not going to really hurt the toe. You just correct it with the synovitis. I'm injecting in the base of the second toe, we call it the MP joint with the metatarsal gland.
And what do you inject?
Injected with Marcaine and steroid. So most any steroid, you use lidocaine too, which is Marcaine because it gets a 4 hours of it, but you leave instead of lidocaine, which is 1 ounce. I think that's the exam of dorsal instead.
Okay, Scott Morris here with Trail Days 2025, Dr. Greg Davis. So now we're going to go over the plantar foot things that we see in the hikers clinic here. Beginning here on the plantar foot is that pain. We've had a couple of those already today. That's what there'll be a neuroma. So the most common place is between the third and fourth toes, and the second most common is between the second and third. And I really don't see a whole lot of difference as far as the amount of those. So any pain right here that's associated with tingling and burning in the toes is a neuroma. The way we usually treat that here is get them a little metatarsal pad and then get them a shot. We actually put the shot in up top to coat that nerve. And 2/3 of the time that helps. 1/3 of the time you need surgery for that. So for here in this clinic, we're just injecting and putting metatarsal pad. Pain at the heads of these bones is called the metatarsal bones. We call it metatarsalgia, which means pain at the heads of those bones. There's not a lot of treatment for that. There's 2 reasons for that. They don't have enough up motion or the dorsiflexion, so we use a metatarsal pad and really stretching that Achilles tendon. Now pain down in here is more plantar fascial pain. This is band, you can see it there, it originates from the heel and inserts on the toes. You tear that plantar fascia because you don't have enough up motion. So it goes along with the Achilles tendon. If you have a tight Achilles tendon, these hikers are doing a lot of hiking uphill and downhill. They need more motion than what they have, and this plantar fascia will tear. I got him tickled there. So for that, we usually use a shot, and if they have inserts, it's very helpful, but a lot of stretching exercises for that and anti-inflammatory treatment.